Greetings, ladies and gentlemen. This will be a revision on a lecture that I did quite some time ago when I was doing my psychiatry lectures about 4 years ago on the topic of sexuality. Now, since then, we have started using the DSM. Actually, I think the DSM came out since then. And so I wanted to just do some revising, add some additional information that I thought would be useful to you both for clinical practice and for test-taking purposes. So I mostly want to stick to test-taking purposes, but there's information that I think will be very useful for you for clinical practice in the US. If you haven't already, please consider subscribing to my Patreon page at www.patreon.com/pwbmd. You can click the link below or the I button on the upper right-hand corner of the video. It should link you up if you like these videos. Consider chipping in $1 a month. A little bit goes a long ways to help keep these videos free. So without further ado, let's talk about sex. So we have some definitions that are very important to get a groundwork here, and you'll want to understand these because a lot of times we confuse them, especially these first two, sex and gender. These are not the same thing, and a lot of people get confused on what's sex and what's gender. So sex is your biology. It's your genetic makeup. It's determined by your genetic makeup. And so typically you're either XY or XX 99.9% of the time. And an XY will almost always be male and an XX will always be female. There's an exception with the XY. If you have androgen insensitivity syndrome, which is a mutation, they will not be able to respond to androgens, and hence they will develop as females in utero. And so what usually happens is that the baby is seen on sonography as female. It's born, looks like a female, grows up, looks like a female, and then hits menarche, but never gets menarche because they don't have ovaries or a uterus. They are essentially, they look like females, but they have no uterus. They have a blind pouch vagina. And that is because genetically they're males. They don't have any of the genes that code for that stuff, but they also are not going to have testicles or anything like that. So these are XY. They're males by sex, but typically their gender is going to be female. Okay, there are some exceptions here, XXY, where you get an extra X chromosome. Because they have the Y chromosome that causes you to develop into a male, these will typically be identified as males when they're born. And they will typically identify as men as well. This is Klinefelter syndrome, which I talk about in the pediatric section, so you can go back and look at that if you want. And then there's X0, or just the single X chromosome. Because they don't have a Y chromosome, they will appear to be females. They will typically identify as women. This is Turner syndrome. And there's some fertility issues that can come with these, as you can imagine. Gender identity is totally different. This is your psychological identity. So it usually will correspond to your chromosomes, but in some cases it doesn't. And when it doesn't, we call that transgender. Okay, so this is how you identify. So you may be a male and identify as a man. That would be considered what we call cisgender, C-I-S gender. On the other hand, if you identify as the opposite sex of what you were born with, then we consider that transgender. So that is your gender. It is how you identify psychologically. It has nothing to do with your chromosomes. It relates to it, obviously. Most people who are XY identify as men. Most people who are XX identify as women, but you cannot make that assumption. Okay, so it does not always correspond to the person's biological sex or sexual identity. And then sexual orientation is quite different, and most people are aware of this, but we define it based on the person's gender, not on the person's sex. Okay, so a person has a gender, they identify as a man, they identify as a woman, and then we ask, what are you attracted to? And if the person is attracted to the opposite gender of what they are, then we call that heterosexual. And that's most people. Most people are heterosexual. They identify as a man, they're attracted to women. They identify as a woman, they're attracted to men. Okay? That is heterosexual. Bisexual means they're attracted to both genders relatively equally. And they may have a little bit of a preference to one gender or another, but that's what we consider bisexual. And then homosexual means they're attracted predominantly to the same gender. Okay, most of the time these people will prefer to be called gay or lesbian. They don't like to be called homosexual, many of them, because a lot of people use this sort of as a derogatory term, kind of like colored or Negro to refer to a black person. We don't say that anymore. 30 years ago, referring to somebody as a homosexual would not have necessarily been offensive. We still use the term homosexual in the medical community, but it's a little bit different because we're not, this is a clinical context. But when you refer to these people as patients, you should refer to them as gay or lesbian. Obviously, lesbian is a female, and gay is usually a male, but some women will call themselves gay women. So there's some terminology that can be a little bit confusing. If you are steeped in Western culture, this is probably very intuitive for you. If not, then this can be something to kind of wrap your head around. Okay, so remember I said that it corresponds to gender. Okay, so if you may have somebody who's born a male who identifies as a woman, so they're transgender, and is attracted to women, then that is actually considered a homosexual transgendered person, even though they're XY and attracted to women. We base sexual orientation based off of your gender, not off of your sex. It's what gender you are and what gender you're attracted to. These are three very different things here, okay? So these are all XY males, born males at birth, but you can see they also have something in common. They also are wearing women's clothing, but these are three very different circumstances. So here on the left, you have a genetic male who's wearing female clothing, but you can see he's doing it in private in his bed. This is called transvestic fetishism. So he dresses in female clothing because he gets sexual pleasure out of it. Okay, that's transvestic fetishism. When he goes out into the walking world and goes to work, he probably will dress in a suit and tie or male clothing. When he's around his friends, he dresses in men's clothing. But for sexual purposes, he enjoys dressing in female clothing, just like some people like to use sex toys. He likes to wear female clothing. This is a transgendered person, so this is somebody who is born a male who identifies as a woman. So this person, and it's proper to refer to a transgendered person by the pronoun that they identify with, so it would be proper to refer to this male as a she. She wears female clothing because she identifies as a female, even though she was born a male and has XY chromosomes. It's always important when you're dealing with transgendered people to ask them what pronoun they prefer to be referred to as. Typically, they will want to be called she if they identify as a female. They'll want to be called he if they identify as a male. And then this on the right is something totally different. This is a genetic male who identifies as a man, but you can see he wears female clothing. He doesn't wear female clothing for the same reason that this man is. He wears female clothing for show, for entertainment purposes. So he may wake up and dress as a male and go to work and dress as a male, but then he goes out to the nightclub and dresses up as a woman for show, for entertainment purposes. This is a drag queen. So this is not somebody who wants to have his penis taken off or wants to get breast implants. This is just somebody who does it for entertainment. Okay? So transgender people, you see them more and more often. This is kind of a contentious issue in our society at the moment, especially as it concerns public access to restrooms and locker rooms. And you can see here these are two more high-profile transgendered people. This on the left is Caitlyn Jenner, who was born Bruce Jenner. This is a male who identifies as a woman. Okay, and then this on the right here is Chaz Bono, who I believe his birth name was Chastity, and this is a genetic female who identifies as a man. Okay, so it would be proper to refer to Caitlyn as a she and to Chaz as a he, even though they're XY and XX respectively. And this is this is a drag queen on the left here, and this is me quite a few years ago. I don't know, 6 or 7 years ago. I was going out to Toronto for a job interview, and it happened to be around the same time as the LGBT Pride festivities, and I looked down from my hotel, and here's all this stuff going on. I didn't know what it was. I went downstairs, and Looked like some fun, and here I run into this drag queen who is dressed as Queen Elizabeth. And so this was something very unusual for me because I grew up in a small town, but it was an experience to say the least. And so I had to get my picture taken with Queen Elizabeth here, and you can see the little corgi here. But yes, I was very entertained by this. So drag queen is not transgender. This is a man who identifies as a man and is going to wake up and go to work dressed up in a suit and tie and usually be around family and friends dressed up as a man would, but enjoys dressing up like this for fun, the fun of it. Not to get sexual gratification, but just for fun. So we're going to talk about some different things here. Homosexuality as well as masturbation, neither of these are considered disorders in the DSM-5 or otherwise. Paraphilias can sometimes be disorders, but it can be a little bit of a dicey situation. Gender dysphoria is technically a disorder, but we're kind of moving away from really considering it a disorder, and it may be changing in the next few decades. And then some of the sexual dysfunctions, which are always considered disorders. So homosexuality is a normal variant of sexual orientation. It was in 1973 that we removed homosexuality from the DSM, and so we consider this a normal variant. And most of these people will live normal lives, they just happen to be attracted to the same gender. Most of these people, if you talk to them, are going to tell you that they started feeling attracted to the same sex since their early teen years, and that's just like everybody else. So once their peers started becoming attracted to the opposite sex, they started becoming attracted to the same sex. They develop totally normal. Their sexual development is totally normal. The only difference from their peers is that they happen to start becoming attracted to the same sex when their peers were becoming attracted to the opposite sex. Otherwise, they develop normally, physiologically they're normal, and it's just the gender they're attracted to is the same rather than opposite. So we do not consider this abnormal, and I cannot stress that enough because there are going to be some people who will tell you that homosexuality is abnormal and blah, 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 blah. Not considered abnormal. In the medical community in the United States, we consider this normal. These people do not need mental help or anything like that, okay? It's idiopathic. We don't know why it happens. There's various theories. Some people say they're born that way. We don't know that for sure. It's probably a little bit of both. You're born with a predisposition to homosexuality, and then there's something in your development that triggers you to turn out that way. Either way, it's pretty ingrained. So these people will typically tell you they don't have any attraction or very little attraction to the opposite gender. There are higher rates of major depression and suicide. This has nothing to do with their homosexuality, though. This has to do with the fact that they grow up or are around in a culture that kind of stigmatizes them. And so you'll run into higher rates of this stuff, especially in the south of the U.S., which is a little bit more conservative. So states like Alabama and Mississippi and Georgia, they're a little bit more religious, biblically fundamental. And so they don't get as much acceptance there. And you can imagine growing up as a gay or lesbian youth in an area where you're not really accepted, your family may abandon you. Of course you're going to have a higher rate of depression and suicide. Whereas you grow up as a gay or lesbian youth in San Francisco, where people are much more accepting of that, you're not going to be as predisposed to this. And hopefully we'll see this start to get better as people are becoming more and more accepting of gay and lesbian people. Hopefully this improves. We have a long ways to go, but the last 15, 20 years, we've really come a long ways. What is not homosexuality? So you may get a parent bringing their son in, 13-year-old son, saying, oh, I caught my kid in with another boy and they were masturbating each other. That's normal teenage experimentation. Parent may ask, well, is my kid going to be gay? We don't know. Maybe. And certainly gay youth will do that, but people who turn out to be straight may do that. And if you talk to straight men and ask them honestly, some of them will tell you that they did that and they just grew up and were attracted to women. And so it's normal. This is part of normal development. Some do it, some don't, but it's normal. Visual comparing of genitals. So some men may be very put off by the fact that when they're in the locker room, they can't help but look at other men naked. They don't get sexual gratification out of it, but they're curious. Not homosexuality. It's not the same thing. That's just curiosity. And then things like hand-holding, kissing, especially among women, you'll see that in the US. Women may hug each other or kiss each other on the cheek. That's not a lesbian. Okay, lesbians will do that, but that's not necessarily somebody who is a lesbian. Just like in Arab countries, you will often see men holding hands. That's a sign of friendship over there. And so that's not considered homosexuality. So if you saw that in the US, though, that would be different. So you can see that a lot of this can have to do with culture, too. You have to take the person's culture into consideration. That goes for a lot of things in psychiatry. So homosexuality is an identity, not a diagnosis. So you cannot tell somebody if they're homosexual or heterosexual or bisexual. Okay, this is a label that a person takes on themselves. I'll tell you this. You get a lot of men. I've had lots of patients who are men who are attracted to men, but they don't identify as gay. They identify as heterosexual, and they are perhaps even married to women, but they're having sex with men on the side. But they don't identify as homosexual or even bisexual. So this is something that you take on yourself. You choose this label, even though you don't choose who you're attracted to. You choose the label. You can be attracted to men, but only have sex with women and try to repress your attractions to men. And so this is a label. Homosexual, bisexual, heterosexual is a label that you take on yourself. It's not the same as who you're having sex with. So you may only establish relationships with women. You may identify as heterosexual, as straight, but you're having sex with men on the side. We need to know that for medical purposes because there are risks involved with some of that stuff. So for medical purposes, we don't want to call people who identify as heterosexual, we don't want to call them homosexuals or bisexuals because that might not be how they identify. And a lot of things with homosexual, bisexual, heterosexual also has to do with who you form relationships with, like monogamous relationships with. And so for medical purposes, we try to make this easy, and we just refer to any man who has sex with men on a regular basis or on a semi-regular basis. We call him an MSM, a man who has sex with men. And this could be a homosexual man, a bisexual man, a heterosexual man, as long as they have sex with men. Or alternatively, less commonly, you'll see WSW, a woman who has sex with women. Okay, so in the literature, especially when you see about things like sexually transmitted diseases, you'll see the MSM population. And that's just anybody, regardless of how they label themselves, a man who has sex with men. Okay? Masturbation. Masturbation is totally normal. Again, you're going to hear people say masturbation is unnatural and stuff like that. Everybody masturbates. I masturbate, you masturbate, everybody masturbates at some point in their life. Now, as you get older, you may not do it as much, or if you're married, you might not do it at all because you have intercourse frequently enough to where you don't feel the desire to masturbate. But a lot of people masturbate. More people masturbate than don't masturbate. So one thing you'll want to differentiate this from, you'll get parents who have toddlers who bring their kids in and say, well, my 2-year-old boy keeps playing with his penis. What am I supposed to do? What's going on? This is normal. This is called the phallic stage. Infants will often engage in self-stimulation of their genitals. This is not a sexual thing. They're just exploring their bodies. So you want to keep an eye out for that, especially if a parent comes in. 2-year-olds don't have a sexual drive. They're not doing it for sexual gratification. They're just exploring themselves. Males tend to masturbate more than females, probably because of a slightly higher sex drive. But women masturbate too, so you can't make assumptions here. It's just with males tends to be more often. The frequency of masturbation usually peaks during adolescent years, but there are adults and elderly people who masturbate as well, maybe even more frequently than some adolescents. So you cannot. Sexuality is a very, very heterogeneous topic. Okay, everybody's unique. Okay, so the frequency tends to peak during adolescent years, during experimentation, but you'll hear of people masturbating in their 80s. Okay, It is not considered disordered unless it interferes with activities of daily life. So if you have a guy coming in saying, well, I get the urge to masturbate at 1 o'clock in the afternoon when I'm at work and I have to take 10, 15 minutes off, go in my car and look at pornography or just masturbate somewhere, that could be disordered because it's interfering with his daily life. Okay, so really, masturbation in and of itself is not disorder, but if it's interfering with your daily life, then we would consider that a disorder. Okay, paraphilias are sexual arousal to objects, situations, and individuals, and this is the important part, that is outside normative stimulation or what is considered to be acceptable. Okay, so again, it's a cultural thing. Okay, a lot of this is defined based on your culture, but for the most part, most cultures will agree with a lot of this stuff. So according to the American Journal of Psychiatry, it's recurrent, intense, sexually arousing fantasies, sexual urges, or behaviors that generally involve non-human objects, which we call fetishism, the suffering or humiliation of oneself or one's partner, which would be respectively masochism and sadism, of children, which we would consider pedophilia or ephebophilia if they're slightly older. We'll talk about the difference between the two. And non-consenting persons, exhibitionism, frauderism, and voyeurism. You can see very, very, very different here as far as if it's a disorder or not. Okay, enjoying having your sexual partner wearing shoes while you have sex with each other is a fetish with shoes, but it's not a disorder by any means. I mean, you can function totally normally that way. On the other hand, if you find that you're attracted to children and you're acting on it, or you're an exhibitionist and expose yourself to people who aren't consenting, that's illegal, and that's a big problem. Okay, so there's differences between these as far as what we consider disorder and what's not. Importantly, it must cause distress to the patient, affect their level of functioning, or break the law in the jurisdiction to be considered a disorder. Now, that being said, there are exceptions with the breaking the law part. Okay, if we criminalized homosexuality tomorrow, we're not going to consider that a disordered paraphilia. Okay, so you have to kind of use common sense here. Management, if necessary, is psychotherapy, but not all these people are going to need management. Okay, it depends on if it's disordered or not. So, paraphilias involving non-human objects, this is called fetishism. Fetish, the word fetish gets thrown out a lot, and for our purposes, it's sexual arousal from objects that are associated with the human body. So, examples could include garments of clothing like shoes or socks or certain underwear, rubber or rubber items, leather items, footwear, etc. A particular type of fetishism is transvestic fetishism, and that's when a person gets sexual arousal by dressing or playing the role of the opposite sex, like we saw in that picture. That's a particular type of fetishism, which is where you enjoy playing the role or dressing as the opposite sex. Not the same as transgenderism. Transgenderism, they don't get sexual arousal out of it, they identify that way. They feel like the opposite gender. Or the opposite sex, and so they identify as the gender that doesn't correspond with the sex that they are born with. Paraphilias involving suffering and humiliation. This is what we know as sadism and masochism, or often gets referred to colloquially as S&M. So sadism is where you get arousal from inflicting pain, and masochism is where you get sexual arousal from receiving pain. So two very different things, obviously. So if you enjoy inflicting pain on somebody, that's considered sadism. Masochism is where you get sexual arousal by being put in pain. Now, sadism can be a problem because if you enjoy inflicting pain on somebody else, if they don't consent to it, that's a big problem. Okay, that can be a sort of a sociopathic thing. And so as long as the person is consenting to it and it's healthy, you're not damaging the person irreparably, then we don't really do anything about it. Masochism, kind of along the same lines, as long as they're not, if they like being spanked or if they like being slapped on the butt, they may get some pain out of that, they may get sexual arousal out of that, not a big deal. If they enjoy being tied up and having their oxygen flow cut off by strangulation and stuff like that, then we get a little bit more concerned about that. So you can see again, whether or not it's disordered depends on sort of the danger level too. This here on the right is a statue of Leopold von Sacher-Masoch, who was an Austrian writer and journalist in the 19th century, wrote some books that sort of had to do with masochism, and that's where we get the name masochism from. Paraphilias that involve children are a big problem, okay, especially pedophilia. So everybody knows what pedophilia is. We have an idea that's sexual arousal that involves intimate contact with or watching prepubescent children. Because this is always illegal in virtually every country, this is a disorder, pedophilia. But this needs to be prepubescent children. There's a difference between this and a phebophilia. We don't hear the term of phebophilia that often, but a lot of people that society labels as pedophiles are actually ephebophiles. So for instance, you hear about the high school teacher who has sex with their 16 or 17-year-old student. That's ephebophilia. That is not pedophilia. Okay, ephebophilia is that you enjoy intimate contact with or watching pubescent teens. The reason that this is a disorder is because it's often illegal. But it's not particularly disordered from a biological standpoint because a person who's 16 or 17 is pubescent. They're fertile people. They can have sex and father or bear children. And back in the Bronze Age, 15 or 16 may have been an appropriate age for a woman, a girl, to bear children. And so at one point that may have been acceptable, but we consider this disordered because it's illegal. In most instances, it's going to be illegal. And of course here we're talking about adults. So if you have a 16-year-old who's attracted to another 16-year-old, not a ephebophilia. It's normal. But if you have a 30-year-old guy who enjoys going to high school football games to watch 15, 16-year-old cheerleaders, we would consider that ephebophilia. This is Herbert the pervert. If you ever watch Family Guy, he's attracted to the boy next door who's only like 15. And that's ephebophilia, not pedophilia. If they were little 6-year-old boys, that would be pedophilia. So it's good to know the difference between the two of these. Paraphilias that involve non-consenting persons. Obviously, because it's non-consenting persons, these are going to be illegal. So this is a problem. Exhibitionism is where you get sexual pleasure from exposure to by exposing yourself to unsuspecting strangers. So this would be like you go to Walmart and you got this guy that shows his penis to some woman who's not expecting it. That's exhibitionism. This is not the same as a college kid that runs in streaks across the football field. Probably he's not getting sexual pleasure out of that. He's doing it just to be funny, not exhibitionism. Okay, so try to understand the difference there. Frauderism is where you get sexual pleasure from rubbing up against unsuspecting strangers. So that may be on a subway where it's very crowded. There may be a guy, and it's usually a male, who rubs his crotch up against somebody else. And a lot of times they'll seek out subways in crowded areas because they can kind of get away with it. And then voyeurism is where you get sexual pleasure from spying on either spying on a person undressing, usually, or engaging in sexual acts when they're unsuspecting. Okay, that's voyeurism. And some of these people, I mean, again, this can be very illegal. Some of these people will set up cameras in locker rooms, and so this is also can be very illegal. Okay, this is what I really wanted to update and get to here. This is gender dysphoria. It used to be called gender identity disorder, and now it's called gender dysphoria. We're trying to kind of destigmatize this because we're understanding that this is probably normal and not a psychological disorder, but it still exists in the DSM. And what it is defined as is a marked incongruence between one's experienced and expressed gender and their assigned gender. So in other words, their gender and their sex. And this needs to last for at least 6 months. We have different classifications for gender dysphoria in children and gender dysphoria in adults. Typically, we'll see this in adults because it's usually adults that will come to us because they're going to want a sex change in many instances. However, in children, when you see this. It may manifest as a preponderance to play with toys associated with the other sex, toilet habits associated with the opposite sex, friends primarily of the opposite sex. But you have to use common sense. You're not going to be expected to diagnose gender dysphoria in a child on the U.S. Illinois. This is very tricky. And gender dysphoria is where they're uncomfortable actually with their gender. Being a little girl being a tomboy or a little boy enjoying playing with dolls is not gender dysphoria. Okay, engaging in acts that are common to the other gender, we call that gender nonconformity. Not the same thing as gender dysphoria. In this case, they actually have to be really not enjoy being the sex that they are born with. So this is how it may manifest, but just having these things is not gender dysphoria, especially in children. So you want to keep that in mind, because you'll get parents that say, well, my little boy likes to play with dolls and likes to wear lipstick. That doesn't mean that they don't like being a boy or that they're going to grow up to want to get a sex change. It may or may not. So gender nonconformity and gender dysphoria are two different things. Adults may eventually get surgery to change their outward appearance or take hormones to transition into the opposite gender. And typically we only do this in adults. It's very controversial to do this in children. Usually in children, they'll give them medications to halt their puberty so that when they become an adult, they can make the decision as to whether they want to have a sex change, because a sex change is irreversible. And we call it a sex change because they're changing their sexual appearance. But that's something we only allow adults to do. So we can change, or we can delay puberty. We can always induce puberty later on. But in children, a lot of times they'll delay puberty, and so then once they become adults, they can make the decision as to whether they want to actually go forward with something that's really non-reversible, like a sex change operation. You can only diagnose gender dysphoria if the patient outwardly expresses disappointment with their current gender or sex and have a desire to become the opposite sex, or they identify as the opposite gender. Okay, this cannot be diagnosed on behaviors alone, particularly in children. So the patient actually has to tell you they don't like the anatomy that they're born with. The management may be psychotherapy if they don't want to get gender reassignment surgery, or it can be gender reassignment, and that can be in the form of taking hormones or getting actual surgery. Okay, so now we'll talk about the sexual response cycle. So this is the sexual response cycle in males and the sexual response cycle in females. Males tend to be pretty predictable. So you start out here with excitement. They get aroused and excited. They tend to hit a plateau, and you consider this pleasure here on the y-axis. And then they hit orgasm. It's irreversible. You can't go backwards at that point. And that's the point of greatest pleasure. And then there's resolution, and usually the male will fall asleep, very stereotypically. There's a refractory period where the man will not be able to achieve another orgasm, but it is possible at a certain point, even though he has not gone completely back to baseline, where he may be able to have another orgasm. That's not terribly common, but some men can do it. Women are a little bit more diverse. So some women will be a lot like men, where they have a very quick excitement and plateau, and they have an orgasm, and then they have resolution. Some women, as you can see in the B curve, the red here, they don't even have an orgasm, but they're okay with that. They just have a lot of enjoyment, and then they have resolution. Now, if they want to have an orgasm and they can't, then we consider that anorgasmia. That's different. That's disordered. And then some women will be able to achieve multiple orgasms in the same sexual encounter. So women are quite different from men. And the reason probably is that there's a very obvious function for the male orgasm, and that's for ejaculation. And there's no need to ejaculate more than once at a time. For females, there is a function for the female orgasm. We believe that the contractions, the rhythmic contractions of the uterus help propel the sperm up to the fallopian tubes. But it doesn't serve the same function as for a man. Obviously, we know that a woman can get pregnant without an orgasm. We see tragically in rape. So it doesn't serve a necessary purpose, it's just helpful. Whereas for men, an orgasm is necessary to father children. Okay, so then there's disorders of desire. So this is obviously what it sounds like. So there's hypoactive sexual desire. This may or may not be a disorder. So all this is low sexual interest. It's only a disorder if it's distressing to the patient. So a lot of times men get older, they get into their 60s, 70s, their testosterone level drops, they don't have as much sexual drive anymore. This needs to be distressing to the patient. So a lot of times what you'll see this in the clinic is that a man or a woman will have low sexual interest, and they may be fine with that, but their partner wants to have sex. And so you may have a wife who doesn't want to have sex, or she just doesn't have much interest, but her husband wants to have sex, and so that can become distressing to the patient because it can affect their marriage. Now that's different from sexual aversion. Where sexual aversion is where you have no sexual interest. As a matter of fact, it really frightens you or disturbs you. You don't want to have sex. It's a phobia almost. A lot of these patients will be rape survivors, and so this is a disorder because in most cases it's going to be distressing to the patient because they want to form monogamous long-term relationships, but of course their partner is going to want to have sex at some point, and these patients they don't want to have sex, they're afraid of sex, and it's distressing to them because it interferes with their ability to have a relationship. So that's sexual aversion, different from hypoactive sexual desire. Hypoactive sexual desire, they're not afraid of sex, they just don't want to have sex. Sexual aversion, they're generally, not only do they not have interest in sex, they're afraid of it. And it needs to be distressing to the patient, but in most cases with sexual aversion, it is distressing to the patient. The management, if necessary, will be by psychotherapy. Because this is a disorder of desire, it may not be distressing to the patient, and therefore therapy may not be desired or necessary. But if the patient comes in to see you, they're typically going to want some kind of therapy because there's some kind of problem with what they're having. Okay, then there's disorders of arousal. So we see this a lot. Female sexual arousal disorder is characterized by a failure to achieve adequate lubrication during sex. So with female arousal, their vagina should become more lubricated. That's part of the female arousal pattern. So this could be due to psychological causes. Nervousness, fear, anxiety can make it difficult for them to become aroused, and then when the man inserts his penis or somebody inserts a penetrating toy into her vagina, it can become painful for them because of a lack of lubrication. That's usually how this will present. One of the things that you want to differentiate out is the usage of any kind of medications that can cause vaginal dryness. So if she's on antihistamines like Benadryl for allergy or for sleep, that can dry you out. Anything that dries out your mouth will dry out your vagina. Or things like anticholinergics like ipratropium. And ipratropium is commonly taken for COPD, so that can dry you out too. So diphenhydramine, ipratropium are probably two of the more common ones, and they can cause vaginal dryness. The management is to consider alternative medications if that's the cause. You can also consider psychotherapy to help them get around some of their nervousness, fear, anxiety. And then synthetic lubricants can be used if it's a lubrication issue primarily. Now with men, and you'll see this a lot in older men, the disorder of arousal is usually impotence. And this is characterized by a failure to achieve or maintain an erection. Now, I struggle to call this actually a disorder of arousal as far as impotence. A man may be aroused, but he can't attain an erection. Psychologically, he's aroused, but he may not be able to attain an erection. So the differential for male impotence, inability to get an erection, is physiological and psychological. You always need to rule out physiological causes first. So physiologic causes are often vascular, so it can be the prominent etiologies from that can be diabetes or peripheral vascular disease, especially when it's an older guy that comes to you. These older gentlemen in their 60s and 70s will tell you they can't get it up when they're having sex. You want to make sure they don't have diabetes, they don't have peripheral vascular disease. One way you can get to that is by asking them if he ever has an erection when he wakes up in the morning. Men often get erections in the middle of the night. A lot of men will wake up with erections, totally normal. If the answer to that is yes, it's probably not a physiological cause. If it's a physiological cause, he's not going to get erections at all, even when he's sleeping or when he wakes up. And so in that case, when you really suspect physiological causes, you want to get hemoglobin A1C, you want to work him up for peripheral vascular diseases to consider the possibility of a medical cause behind his impotence. Otherwise, we consider it psychogenic ED, psychogenic erectile dysfunction. You'll see this occasionally in men with anxiety disorders. They have issues with attaining an erection because they're very self-conscious. You may see it in young men who are who may not be attracted to women, who are trying to be heterosexual, who are trying to be attracted to women, who in fact are repressed homosexuals. That's a little less common, but that's psychogenic ED. And in that case, there are things we can do for them. Usually with psychogenic ED, we will give them Viagra, sildenafil or tadalafil, also known as Cialis, as a placebo. Okay, so with psychogenic ED, or with if we've worked up and we're treating any kind of underlying cause, we will give Viagra or Cialis. It may be because we're giving it to work on its own, or it may be because, especially in the case of psychogenic ED, we're giving it as a placebo. Because for them, they can get an erection, they're just worked up about it, and they're psyching themselves out. So we give it to them to kind of calm their nerves in a sense. So we're using it as a placebo. It will help them. It will make them more sensitive. But effectively, we're giving it as a placebo. You could probably give them a sugar pill, and if they feel relieved that they've taken something to help them, a lot of times it'll help with their anxiety. And so it is perfectly appropriate. As long as there's no contraindications, it's perfectly appropriate to give a man with psychogenic ED, to give him sildenafil or tadalafil. Okay, these are, there's very few contraindications. As long as they're not on nitrates or anything that lowers your blood pressure, for the most part, these are pretty safe drugs. Okay, then there's disorders of orgasm. So this would be things like premature ejaculation. Premature ejaculation you'll see a lot in teenage boys, young men. College-age guys come to you, they say, I've tried to have sex with my girlfriend, and as soon as I put the head of my penis in her vagina, it's over. Okay, this is very, 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 very common. So all it is ejaculation earlier than desired. And what you do for these is you teach them sexual techniques like the squeeze technique. So when they feel they're going to have an orgasm, they take the head of their penis and they pinch it. Okay, gently pinch it. And that helps ward off an orgasm in most of the time. You can also use SSRIs like Zoloft, sertraline, because of the side effects of that actually causes anorgasmia, delayed ejaculation. For most of the patients that you give this to, that's going to be a very unwanted side effect. But in patients who have delayed ejaculation, who have premature ejaculation, the delayed ejaculation side effect may be what they're looking for, and so that may help them. So you can consider that. Anorgasmia is the total opposite. So this is a recurrent or persistent inability to achieve orgasm. First thing you want to do, rule out SSRI use. If they are using an SSRI like Zoloft or Lexapro, you can switch them to a different antidepressant, something like Wellbutrin, for instance. Bupropion has a very low sexual side effect profile. Of course, you want to be careful. Don't use bupropion in patients with seizure disorder. That's a common board question. The management is psychotherapy. Now, when you talk about anorgasmia, these can be very difficult to treat if it's not related to any kind of medications the patient is on. So you will not be asked that on the test. You'll want to refer these patients either to psychiatrists who are specialized in sexual disorders or to sex therapists. Disorders of pain during sex include dyspareunia. Dyspareunia is pain that's associated with sex, but not associated with lack of lubrication or any organic medical causes. So the differential includes female sexual arousal disorder. This is where she does not become aroused and hence does not lubricate. Endometriosis, where her pain is going to come from those inflammatory, angry areas of endometrial tissue that are causing the pain directly. Hypoplasia of the vaginal introitus. Obviously, if her vagina is not big enough and you insert a large penis or a large toy into her vagina, that's going to be painful. Lichen sclerosis, which is an autoimmune issue. They get these white plaques that you'll need to treat, usually with steroid creams. And candidiasis, obviously a fungal infection that you can treat very easily. So when you have women coming to you with dyspareunia, and typically it's going to be women with dyspareunia, you'll want to get a good pelvic exam to rule out some of these things. Management for dyspareunia is psychotherapy. Vaginismus is different. Vaginismus is actually an organic disorder. It's an involuntary contraction of the outer one-third of the vagina, which results in pain during penile penetration or penetration with any kind of penetrative object. Management is techniques like using dilators and fingers. Very gradually, if you use these gradual dilators, a lot of times it will help them. So these are dilators here. You could start these women off with a small dilator. As they get more comfortable, they can use bigger and bigger and bigger and bigger ones until you get to the size of the penis or whatever the desired size is, and that will usually help them. Again, referral to a sex therapist is very useful for these things. They'll know a lot more about this than you will. All right. You can also do the fingers, so the man or partner inserts his fingers into her vagina, and so you can do it that way too. This is a little bit easier because you can sort of measure it. Okay, so with that, I will leave you with Sue Johansson. She is a Canadian sex therapist. Had a show quite a while ago. I used to love watching this show when I was in college. I thought it was very entertaining. It's like watching your grandma talk about sex. Kind of awkward, but here she is.
And
Thank you.
my mother and I both love your show.
Isn't that cute? You watch it together?
Thank you so much for making yourself available to all of us here in the States. Love your show.
Pleasure. Hello and welcome to Talk Sex. I'm your host, Sue Johansson, and my mission in life is to promote sex education, to dispel myths and misconceptions so you can enjoy being the sexual human being that you were born to be.
I have a quick question. I don't know how true this is, but I was told by someone who's dating a dentist
Yes?
that the dentist told him that if she looks into the back of the throat of her female patients, that she can tell whether or not they have oral sex, and particularly if they swallow a lot. Is that true?
There's going to be an awful lot of people in an awful lot of trouble if that's true.
Me and my girlfriend were wondering if having sex in a hot tub is a good idea or not.
Not.
No?
No. Sex in a hot tub, okay? Now, the hot tub has got chlorine in it, hasn't it? Absolutely, got chlorine in it, I know that.
Uh-huh.
And so, you're having sex under the water.
Right.
You're thrusting penis in vagina. You are forcing water into her vagina.
Oh.
Ooh, that's right. It's got chlorine in it. You wonder why her vagina gets sore, raw, red, irritated? Ugh, ugh. And then they're worried that there's a possibility that the water will go up through her cervix, through her uterus, and into her fallopian tubes, and then drip into her abdomen.
Oh.
And there is some concern that that might cause endometriosis.
I just called to ask, when my girlfriend and I have sex, either with a dildo or with her fingers, when I'm getting ready to have an orgasm, I often have like vaginal farts or queefs.
Yeah.
I'm wondering, is there any way to stop doing that?
No, why? Vaginal farts are wonderful things.
It's something we can do. Guys can't do it. And ours don't stink. Theirs do. Ooh.
I guess
No.
it's just embarrassing. You know?
Oh, no. You just let fly. Is he using condoms for bum sex?
No.
Lisa, think.
Yeah.
He is putting his penis in your rectum, right?
Uh-huh.
Uh-huh. That rectum has feces in there. Feces are loaded with bacteria. Now he's going to pick up some of that bacteria on his penis, right?
Mm-hmm.
And then he's going to have intercourse with you, vaginal intercourse, and he hasn't washed his penis and he wasn't using a condom. You're going to get the infection. I'm not worried about him, I'm worried about you.
Hot stuff.
Time for the hot stuff bag. Now, this toy, it puts a whole new meaning to the expression. Desperation is the mother of invention. This is called the vibrating turbo suction tongue. You close the valve and you draw the air out, okay? And now you've got a vacuum in there, and that'll give you an erection. So you draw the air out first, and it's locked there. Then you turn the vibrator on, okay? Now then, it vibrates, it's not vibrating. And it is a strap-on. Now, people think that strap-ons are kind of kinky, but they have their uses. Don't ask. Anything with more than 3 buttons, I'm guaranteed to mess up. Well, you know what? They couldn't leave well enough alone. And what they've done is put a tiny camera into the end of the dildo. Yes, you heard right. A camera that hooks up to your TV. It gives a whole new meaning to I'm ready for my close-up now, Mr. DeMille. Here, let me show you. I'm going to use my hand for this one. And you put it there, and it comes up on the camera. Well, all I can say is thank God it's in black and white. Oh, now she's working. Thanks a lot. There's a head in there that is called an exciter, and it triggers ejaculation. On the Hibachi Hot Stuff of Love, we are rating this a 3 briquette sex toy for guys who are not perceptually handicapped.
You need to be cloned so that you can teach everybody in the world.
I think there are people out there who think one of me is one too many.